So good morning. I'm Luis Blanco Jr. I'm an associate professor of pathology at Northwestern in Chicago. I also am the program director for both the residency as well as the breast pathology fellowship. And today I'm joined by my colleague.
Morning, everyone. Dr. Bonnie Choi here. I am an assistant professor of pathology at Northwestern. Also, I do cytopathology, and this is the part that I'm wearing my hat today. And also GU pathology. I am the associate program director for the residency program.
Great. So today we're going to go over a practical guide into the workup of metastatic breast cancer in cytologic and histologic specimens. We have no financial disclosures, and we will not be referencing any off-label usage of pharmaceuticals or instruments. So our goal today, our learning objectives, include recognizing new therapeutic markers, specifically PD-L1, and how they are properly interpreted to guide breast cancer treatment. Second, to determine how to appropriately interpret well-established biomarkers, the ones we're all familiar with, ER, PR, and HER2, using the most updated testing guidelines. And finally, to develop a practical workup to confirm breast primary, especially with the new immunomarkers that are available now, including SOX10 and TRPS1 or TRPS1. And Dr. Choi and I decided to put this together because, as you may know, it would not be unusual to get cytospecimens in patients with metastatic breast cancers for workup, and it becomes a challenge with those very tiny specimens. So before we go into the first topic, just out of curiosity, how many of you in the audience are trainees? Anyone? Okay. How many do breast pathology? Awesome. So you guys will be very familiar with a lot of the things that we talk about. So hopefully you don't fall asleep, especially since it's so early in the morning. All right, so we're going to start off with talking about PD-L1. So this has been sort of a hot topic the past few years. So PD-L1, or programmed death ligand 1, is an immune checkpoint protein. So PD-L1, as you can see in this diagram here, is one of the primary ligands that PD-1, you can see here, interacts with in order to inhibit T-cell activation and proliferation. Now, in this diagram, you can see the blue cell here is the T-cell, whereas the green cell here is the tumor cell. Now, tumor cells can actually express PD-L1 as a result of oncogenic signaling, and this results to an adaptive immune response that allows the tumor to become resistant and avoid T-cell mediated anti-cancer immune response. So there are multiple immune checkpoint inhibitors that are now available, both anti-PD-L1 as well as anti-PD-1. This is the same diagram that we just went over. If you look down here, what these immune checkpoint inhibitors do, here anti-PD-L1, and then here in the black anti-PD-1, is block this PD-1, PD-L1 complex in order to allow the T cells to actually resume killing the tumor cells. So ultimately, the effect of the immune checkpoint inhibitors is a decrease in immune cell inhibition and therefore an increase in anti-tumor immune response. So there are three major phase 3 clinical trials that have led to FDA approval for the use of immune checkpoint inhibitors in breast cancer. And we'll go over these three briefly. There's Impassion 130, Keynote 355, and Keynote 522. So for the Impassion 130, this trial had 902 patients who had untreated metastatic or unresectable locally advanced triple-negative breast cancer. They looked at the anti-PD-L1 immune checkpoint inhibitor atezolizumab, and they did a 1-to-1 randomization. So one arm was treated with atezolizumab plus nab-paclitaxel, and the other with placebo plus nab-paclitaxel. And if you look at this chart here, the x-axis here is in months, and the y-axis here is the percentage of patients. The blue line represents the atezolizumab group, while the red line represents the placebo group. You can see that the median survival in the atezolizumab group the median was 25 months compared to only 15.5 months in the placebo group. So, given the results of this trial, in March 8th of 2019, the FDA actually granted approval for the use of atezolizumab in combination with nab-paclitaxel for PD-L1 positive, unresectable, locally advanced, or metastatic triple-negative breast cancer. And this was approved only based on the specific Ventana PD-L1 SP142 clone diagnostic assay. How many of you brought this in? We did. We brought this in to the lab when this was approved, and we got a lot of requests from our clinical colleagues for this immunomarker. And for this trial, they defined PD-L1 positive tumors as those with PD-L1 positive tumor infiltrating immune cells of any intensity covering more than or equal to 1% of the tumor area. Now, I'm sure you guys are aware in other organ systems, we also look at tumor cell expression. Sometimes we compute a score, which Dr. Choi will go over in a little bit. In this trial, there was actually almost 100% overlap with those who had more than or equal to 1% TIL PD-L1 positivity and tumor cell positivity. And that's why the recommendation was just to look at the TILs. And of note, you do need a minimum of 50 viable tumor cells in order to be able to assess this adequately. Again, comes into play when you're dealing with the cytospecimens. So here's just an example of nice dark brown PD-L1 staining in the lymphocytes and macrophages that are interspersed in between these larger nests of tumor cells. Maybe there's a little bit of staining in the tumor cells as well, but definitely more than 1% TIL PD-L1 positivity with SP142. So this patient would be eligible for atezolizumab. Now, the next trial is Keynote 355. This had 847 patients with untreated, locally recurrent, inoperable, or metastatic triple-negative breast cancer. And in this trial, it looked at a different drug. This is an anti-PD-1, pembrolizumab. And what they did was a 2-to-1 randomization of pembro plus chemo versus placebo plus chemo. And their primary endpoints were progression-free survival and overall survival. And they had a pre-specified subgroup analysis based on 2 cutoffs for PD-L1, which was a CPS greater than or equal to 10 and a CPS greater than or equal to 1. So CPS is combined positive score. And like I said, Dr. Choi will show us how to do that in a little bit. And this is based on a different machine and a different clone. So this was based on DACO using the 22C3 clone for the PD-L1 immunostain. So here are 2 charts. Both of them have months for their x-axis and then percentage of patients on the y-axis. The one here that I am highlighting, chart A, represents analysis using a combined positive score of greater than or equal to 10. And the one here on the right, graph B, represents when they use a CPS cutoff of more than or equal to 1. Now, if you follow the blue line, that represents the pembro group, and then the red line represents the placebo group. And if you look at the median for the pembro group, survival was 9.7 months compared to 5.6 months in the placebo group using a CPS of greater than or equal to 10, and this was statistically significant, versus in the using a CPS score of 1, there was a much closer difference, 7.6 months in the pembro group compared to 5.6 months in the placebo group, and actually reported as not statistically significant. So based on this trial, in November of 2020, the FDA granted accelerated approval for the use of Pembro in combination with chemotherapy for PD-L1 positive, locally recurrent, unresectable, or metastatic triple-negative breast cancer. And again, pembrolizumab is an anti-PD-1, and it's approved only based on the specific DACO22C3 assay. And given the results, based on this trial, PD-L1 positivity was defined as those that had a combined positive score of more than or equal to 10, or a CPS of more than or equal to 10. And this was actually converted to full approval in July of 2021. So what is this CPS? I'm going to turn it over to Dr. Choi.
All right, so we need to do some math here. So I guess the first thing to point out as we're working on metastatic breast cancer specimens potentially is that are we working with tissue that is on a core, on a resection, versus, let's say, on a cytospecimen where you're just getting cell block without any architecture. And this comes into play a lot, especially when we're talking about the CPS score. So as you can see that it's a combined positive score. We are also familiar with, when we're talking about PD-L1, the TPS score, which is the tumor positive score. In that case, a lot of the times when we use TPS, that's in specimens such as lung. So you have to really be aware of what kind of carcinomas that you are actually working on, because based on the trials, as you have seen earlier, it's demands whether or not you report a TPS versus a CPS. And we'll go into a little bit more about why the CPS score, depending on the type of specimens that you're working up with, might be potentially an issue. But let's talk about how we even calculate the CPS score first. I always have to remind myself and have like a little cheat sheet with me of the differences between TPS versus CPS. First, of course, is that you want to look at the number of staining cells that are staining for PD-L1. What are these cells that we need to count is that tumor cells. So if you had talked about TPS, those are the cells that you want to look at. But in addition to the tumor cells, we also are going to include lymphocytes and also macrophages that stains for PD-L1. All of that goes on the top of the equation, and then you divide it by the total number of viable tumor cells. So you kind of have to get an idea of just the total number of cells that are tumor cells, and then multiply that by 100. And just to point out on the very bottom that we do need a minimum of 100 viable tumor cells for adequacy. And especially with small specimens, like little biopsies that we get for this type of workup, the number should be something that you keep in mind, because if it goes any lower than that, the interpretation of our staining for determining the percentage would be a little bit more skewed, and might not be very representative of the whole specimen. So try to at least have 100 viable tumor cells in your specimens before you do this. Sometimes we get pushed back a little bit, on the clinical side, but we do insist that if the specimen is too small and there is not enough to point out 100 cells, that we just say that there is too scant of tissue and we cannot perform a PD-L1. So we do try to take a stand on that and just say that it won't be meaningful, it won't be very accurate, and we just move on from there. So with that in mind, so what does that mean when we say positive PD-L1 staining? For tumor cells, we're talking about specifically is that any linear membrane staining is included as positive. So if we think about HER2, the positivity of the strength of it, is it like a 1+, is it a 3+ staining? On the image on the left is very faint. staining, and now on the image on the right, the tumor cells are staining very strongly. But either way, any type of staining, all the way from the left side, the weak kind of staining, all the way to the very strong staining on the right image, all of that counts as linear membrane staining for our tumor cells. So then, other staining patterns for tumor cells that is acceptable is partial linear membrane staining, and so that is okay. If it doesn't entirely circumferential on the membrane, that is totally fine. A little bit of partial linear membrane staining is okay, but any cytoplasmic staining alone without membrane staining is not counted. So in addition to our tumor cells that gets counted, we also have the number on the number of positive staining cells. We do count our immune cells, and for lymphocytes and macrophages, it's a little bit more lax in the sense of both membranous and or cytoplasmic staining is allowed. And so I think we're moving upon our first kind of polling question. The image will go away, so I'm going to stay here for a few seconds while we look at the question, and then we can talk about what the answer choices are. So in computing our CPS, which we just talked about in this case, the immune cells, in which area would you include? So we have an area A, we have an area B. Would you count just A, just B, both A and B, or neither? So with that image in mind, again, I'm going to go to the poll. I'm going to start this. Oh, it works. Uh-oh. Okay. Oh, not me. Yes, it's 8362-758. 8362-758. Someone got it. Nice. I'll give everyone a few more seconds. It's either everyone is in 100% agreement, or just one person was able to get in. This is fun. All right, so far we have 75% saying just the immune cells in box B, 25% saying both box A and box B. Okay. All right. We will move to the next slide to review the answer. All right, so the answer is the green box, which is B. So only the immune cells directly associated with the invasive tumor counts. So why not the box A, which is the upper box in red currently? It lies outside of the area that is defined as directly associated with the tumor cells. So general rule is to only include PD-L1 positive immune cells that are within approximately 0.5 millimeter from the tumor cells. So that translates to about a diameter of 40x field in high power. So just really all the immune cells that are within in association with the tumor cells, and then if you're going to talk about any adjacent adjacent immune cells next to the tumor cells, it should really be right up against it. This also applies to the evaluation when the metastatic breast cancer goes into the lymph node. So just the immune cells right around. It gets a little bit difficult, but try to apply the rule of if you're at 40x, that's kind of just the distance that you want to go to in counting the tumor cells. That's right next to the immune cells, right next to the tumor cells. All right, with that, we're going to talk about another trial.
All right. So the final trial in breast cancer that looked at immune checkpoint inhibitors is Keynote 522. This had 1,174 patients with high risk, early stage triple negative breast cancer. So this is the first population that we looked at that was not locally advanced and metastatic. There were two groups that were included in this study. Those with tumor size greater than 1 centimeter, but less than or equal to 2 centimeters. So that's a T1C, with nodal involvement, either N1 or N2, or tumor size greater than 2 centimeters, so a T2 to a T4, with or without nodal involvement, N0 all the way to an N2, and with no evidence of metastatic disease. They did a 2-to-1 randomization to neoadjuvant pembrolizumab or placebo plus chemo, followed by adjuvant pembrolizumab or placebo. And the primary endpoints for this trial were pathologic complete response and event-free survival. And they had a pre-specified subgroup analysis using a CPS cutoff of more than or equal to 1. And similar to the other Keynote study, this was based on using the DACO22C3 clone for PD-L1 immunostaining. So here's a table that shows you the endpoints in this column. This is the group that was treated with pembro with chemo neoadjuvantly, followed by adjuvant pembro. And then this is the group that was treated with placebo with chemo, followed by adjuvant placebo. Again, 2-to-1 randomization, so 784 patients in the pembro group, 390 patients in the placebo group. And if you look at the path complete response rate here, in the pembro group, it was 63% of these patients compared to 55% in the placebo group. So there's a difference of almost 8% in the two groups. And then if you look at event-free survival, there was also statistically significant difference between the two groups. 16% of the pembro group had events, while 24% of the placebo group had events. So, looking at the subgroup analysis, they found that event-free survival was improved, actually both in the PD-L1 positive group as well as the PD-L1 negative group. So, based on this trial, in July of 2021, the FDA actually granted approval for the use of pembrolizumab as neoadjuvant therapy for high-risk, early-stage triple-negative breast cancer in combination with chemotherapy, followed by single-agent adjuvant pembrolizumab. And this was approved in the overall population with no need for a companion diagnostic assay. Now, here's a summary of these three trials. So the first trial looked at atezolizumab, and this was indicated for advanced triple-negative breast cancer. They used the Ventana SP142 and actually defined PD-L1 positivity on immunostaining as tumor-infiltrating cells more than or equal to 1%. The second trial was looked at pembrolizumab in advanced triple-negative breast cancer using DACO22C3, and they had a definition of PD-L1 positivity as those having a combined positive score of more than or equal to 10. And then the last trial that we just talked about also looked at pembro, but this time in early triple-negative breast cancers. And they found that there was no difference in the PD-L1 positive and PD-L1 negative groups, so no diagnostic assays are needed for this group. Now, I asked earlier how many of you brought in the Ventana to be able to do the SP142. We were one of the institutions. This actually, about a year ago, was taken off of the market. So you can forget everything I taught you about that. So you should not be getting any request for SP142 at this point. And it wasn't only taken away for breast cancer, it was removed completely off the market. I don't know the details off the top of my head.
And before we kind of move on off the topic of PD-L1 too, as we kind of wrap up this topic with our 22C3 and how to calculate CPS scores, do also remember that certain specimens, we don't have architecture. And so with the calculation of it, we're talking about tumor cells. We're also talking about the immune cells that are right in association with the tumor cells. So in specimens that you will have metastatic breast cancer, and you might get a request on getting a PD-L1 CPS score. So let's think about tumor cells in fluids, in pleural fluids, in peritoneal fluids. Let's say there is no architecture. So in those cases, we really have to be aware that the limitations of the type of specimen we have, and we cannot actually perform a CPS score on those type of specimens. So keep that in mind. If it's a small biopsy, but there's still a little bit of architecture, you can certainly do that, again, with the cutoff of at least having 100 cells to include, but keep in mind of the type of specimens you're working with.
Thank you. All right, I think the next one, no, this one is not a Mentimeter, but just a question, just a show of hands. Do you think we can use the various available PD-L1 assays interchangeably? The DACO22C3, the SP142, etc. How many think yes? How many say no? Awesome. I know, someone really needs to iron this out. All right, so here is data. Actually, this is from a non-small cell lung cancer cohort, but two graphs here. The one on the left, labeled B, looked at tumor cell distribution, and the one here on the right looked at immune cell distribution of PD-L1 positivity. The dark teal here represents less than 1% expression, and then as the colors become lighter, you go to the lightest color, which represents more than or equal to 50% positivity. Now, I just highlighted here for you the two assays that we talked about, 22C3 here and SP142, and you can see that if you look at the tumor cells with these two different clones, many of the cases will have less than 1% staining with the SP142, 60%, a little bit higher than 60%, compared to just a little bit higher than 30% using the 22C3. And then if we look at the immune cells here on the right, 22C3, many of the cases will have between 1 and 10% PD-L1 positivity versus almost 50-50 with SP142. So no, unfortunately, the different PD-L1 assays that we have are not all built equal, and therefore we can't use it interchangeably. So keep that in mind as well. So after what happened with SP142, we didn't actually work on bringing the DACO22C3 in-house. So our practice is if we get a breast cancer case with a request for PD-L1, we actually just send it out at this point. How many of you do it in-house? All right. We're in good company. Any questions on PD-L1 before we move on to the next topic? Thoughts, comments? We going too fast, too slow? Everyone still awake? Great. Okay, so the next group of markers we'll talk about, you guys are very familiar with, since most of you do breast pathology. We're going to look first at the hormone receptors, estrogen receptor and progesterone receptor, or ER and PR. So you all know we've way back in the day, 1980, all the way to 2005, chemotherapy decisions were actually based on tumor size and nodal status. And endocrine therapy was added if the tumor was ER positive. And the presence of both ER and PR by immunohistochemistry correlates very well with response to anti-estrogen treatment, such as tamoxifen. And trials have shown that endocrine therapy responsiveness is observed even with very low expression of ER of 1%. Although to date, there is much more limited data in patients with 1 to 10% expression of ER. And then in addition, we use PR testing as a prognostic marker in this ER positive group. So as you can imagine, given how important these tests are, the American Society of Clinical Oncology, or ASCO, and the College of American Pathologists established guidelines for ER and PR testing. And the first set of guidelines were actually published in June of 2010, and there was a more recent update in May of 2020. Now, before we go into the actual interpretation, we did want to go over some of the pre-analytical variables that we really need to think about when doing these tests. So, the time from tissue acquisition to fixation should be as short as possible. So this would be the cold ischemia time, so the time the specimen is removed from the patient before it is placed in formalin. And samples that are for testing of these hormone receptors should be fixed in 10% neutral buffered formalin for 6 to 72 hours. So keep that in mind as well. And of course, we need to note the cold ischemia time, the fixative type, and the time the sample was placed in formalin, either in the accession slip or in the report. This is actually something I'm curious about. Do you guys put this information in your actual report? Do you do it in, how many put it in the gross description? Anyone put it up top or in a note or somewhere else? Yeah, this one is interesting. We also put it in the gross description.
Another more potentially controversial topic would be how difficult or easy is it to work with your surgery team on getting the specimen from the OR to the growth room in a acceptable time so that we can put the tissue in formalin accordingly.
Mm-hmm. Right.
Mm-hmm. Yeah.
We also see it with employees, they don't want the time out of the body and stuff like that because they don't know the significance. And so it's a lot of re-education every couple of months.
Sounds like education, continued education of the staff. Okay.
Where I used to work, we gave an in-service every 6 months.
That's a great idea.
Nurse turnover.
In service. All right.
You are usually combined it as well.
Mm-hmm.
What INR meant and some other timely topics that have arisen.
That sounds like a great idea.
Our issue is with the little not outpatient, but the outlier hospitals
Mm.
that come to our main lab. Like they'll do procedures in the afternoon on Friday, so we don't gross them until Saturday.
Right. Yeah.
It seems like a lot of us in
Similar.
situations where we do have affiliated hospitals and educating those affiliated hospitals and bringing the specimen in could be a very difficult conversation and reminders, but it seems like we have some ideas of ways to continue educating the staff, and hopefully that is something that we can optimize with the length of time that we have to continuously do this.
Yeah, one of the things that we did a couple of years ago, we had a big problem with getting the time out of body as well. So we actually created little stickers that has time out of body and then time, place, and formalin. So as a reminder for both sides, the OR side to give that information, and then for our residents and PAs to remember to take note of what time they put it in formalin. So that may help as well. We haven't had as much of a problem since we added stickers to all of our breast specimens. Oh, that's great. Yeah, we tried that too, but I think a bright orange neon sticker, they tend to see that a little bit better. But yeah, that would be another way to do it for sure. Yes, yes. All right. Okay, so now let's move on to how we actually interpret the stains based on the most updated guidelines from ASCO and CAP. So samples with 1 to 100% tumor nuclear positivity for either ER and PR are interpreted as positive. What changed in the 2020 guidelines is for ER. So if you have staining between the 1 to 10% range, you actually should be reporting this as ER low positive and not just ER positive. And again, this is for for ER and does not apply for PR. For PR, anything greater than or equal to 1%, you just report as PR positive. And as I mentioned earlier, this is because there's limited data on the overall benefit of endocrine therapy for patients with low levels, 1 to 10% ER expression, but there is some suggestion of possible benefit. So technically, these patients are eligible for endocrine treatment. However, there's other data that suggests that these tumors may be heterogeneous in both behavior and biology, and often actually have gene expression profiles that are more similar to ER negative cancers. So this low positive group was really created to give our clinical colleagues a little bit more leeway as to how they want to treat the patient depending on other characteristics, as ER positive and add endocrine therapy, or as a more triple negative, more aggressive breast cancer. Okay. Is that projecting okay? It's kind of tiny. It's tiny on my side. All right. So again, if you have more than 10% staining, intensity is moderate or strong, you report that as ER positive. If you have less than or equal to 10% staining or the intensity is weak, you actually do some steps to make sure your test worked well and is optimal. And if you have less than 1% of the cell staining, then that would be reported as ER negative. And if you're in the 1 to 10% range, then that would be reported as ER low positive. Just another way of looking at it. Okay, it's still me. All right, so taking a look at this is actually a TMA of tumor. You can see the nice cords of tumor cells on low power here with brown staining. Gave you a little bit higher power here. This again is not Mentimeter, so we'll just do show of hands. How many would report this as low positive? Just positive for ER. Yes. And yeah, so this one, it's pretty much all of the tumor cells. So this would be somewhere in the 91 to 100% tumor nuclear staining. And then intensity, this picture is a little blurry, but it's actually really nice and strong. You can see the nice dark brown nuclear dots even at low power. Okay, here's another case. This one is PR testing in an invasive ductal carcinoma. In this case, approximately, as you can see here in the TMA, approximately 71 to 80% of the tumor has nuclear immunoreactivity. What intensity would you assign for this case? Who says weak? Moderate? Strong? Yeah, this would be moderate overall. I know there are some definitely that are a little bit weaker, but I would report this as moderate. Okay, how about this one? Low power. Don't really see any brown staining. Higher power of this invasive ductal carcinoma. There's maybe some. Who would report this as positive? Negative. Low positive. Yeah, so this would be, I know it's hard to see because I'm giving you just one high power, but if this was representative, it'd be somewhere in the 1 to 10% tumor nuclear staining weak. So this would be an ER low positive case.
Sometimes we struggle with the percentage also. Just kind of curious too, by show of hands, and what would you do when you have a case? Do you have a colleague that you can go to show and kind of confirm and decide on the percentage? It seems like a lot of people are nodding their heads. Yeah, that's what we do too. In both cytology and also in breasts, we kind of go back and forth, just go down the hallway and show each other just to make sure that on difficult cases for ER, PR, HER2, all of the above, that we show another person and see what they think in these more difficult cases.
All right. Okay, we're coming up to our next Mentimeter question. So again, we'll show you the pictures, give you a few seconds before we go to the question. But here we've given you what the tumor looks like on H&E, and this is the corresponding ER immunostain that looks like there's less than 1% ER positivity. These are normal residual ducts here on the right. So it looks like the test is working. So given the ER result in this case, what would be your next step? Give you a couple more seconds to look at the picture. All right. What would your next step be? Would you report this case as ER, less than 1%, negative? Would you report it with some sort of comment? Would you repeat testing on the same sample? Would you request another biopsy in order to repeat the test? Or would you just wait for the excision specimen and repeat it on that once it's available? And again, the Menti code is 8362758. There's maybe a best answer. Yeah, there's two possible answers, but there's one that's slightly better. Okay. Our pie chart's changing a little bit. Everyone happy? Okay, I have 80% of you who would report it with a comment, and about 20% that would report it as less than 1% negative. Move on to the next case, because we're all too busy. All right, so something that you really do need to be aware of when you're interpreting ER and PR is the morphology and expected biology of the tumor. So in the red box here is a list of highly unusual ER negative results, and these include a low-grade invasive carcinoma of no special type, the one that we just call invasive ductal carcinoma, lobular carcinoma, classic type, pure tubular, cribriform, or mucinous carcinomas, and encapsulated papillary or solid papillary carcinomas. So really unusual for these low-grade tumors, low-grade group of tumors, to be negative for ER. So if you do get a result like that, stop for a second and think about it. And there's also a group here highlighted in the green box of highly unusual ER-positive tumors. And this group includes metaplastic carcinomas of all types, adenoid cystic carcinomas and other salivary gland-like carcinomas of the breast, secretory carcinoma, and carcinomas with apocrine differentiation. So opposite, if you get a tumor that falls into this group that's ER-positive, also make sure that everything worked all the way from your pre-analytical variables all the way to interpretation. And you can see here in the note that if you get one of these unusual results, such as in our case, where you had a tumor that was predominantly tubule forming, therefore low grade, you would expect that to be ER positive and not ER negative. So in this case, You may want to, as Dr. Choi mentioned earlier, consult a colleague. Just make sure you're looking at the correct area. Make sure the test actually worked. We did have internal control in this case, so it looked like it worked. And repeat the testing. So that's actually the first step, is repeat testing on the same specimen. And once you are sure everything is valid, your controls work, both external and internal, then you can report it with a comment saying that this is a highly unusual result for this particular morphology, and you may want to confirm the results either with additional sampling or once you get the excision specimen. So all of those choices were actually correct, just a matter of which one you would do next. All right. Any questions before we go through some more cases? No? All right. Dr. Choi.
Okay, so some metastatic breast cancer cases for us to look at. So this is one of our first cases, and on the top is an H&E of the core biopsy that we got from interventional radiology. So in our institution, I know everyone does things a little bit differently. For us as cytopathologists, we work really closely with interventional radiology for on-site evaluations when we get the cores getting sampled. So we were downstairs. The core that we got was lightly touched on a slide, and we were able to do a diff quick on it, confirm that yes, indeed, they got into the lesion. And then on the next day, we work up our core biopsy. And so on the top image on the left, you can see just a little hint of the hepatocytes, the background liver parenchyma on the left, and then it is that infiltrative tumor cells that are mainly on the majority part of our image on the top. And so our tumor cells, of course, if we want to just do a Gallifrey to confirm that this is indeed breast cancer. We will talk a little bit more about that later also. But once we have decided that, yes, indeed, we do have metastatic breast cancer, we often do our biomarkers, so ERPR, HER2 for our clinical colleagues. They will often request it too. I'm sure that everyone is familiar with the fact and that depending on new sites, depending on the time it has been for the metastasis, whether or not it's on the same site, we do get requests for repeating ERPR HER2. So we do our ERPR at this point. We'll talk about HER2 later. And I would say, I guess by show of hands, intensity-wise, would anyone call this weak? No. Moderate? No. Strong? I think that's definitely very strong for both ER and PR. And based on the image that we have on the top and where the tumor cells are, I would say both ER, PR percentage-wise, we're definitely in the positive for both. I would say that we're at least in that very high end of 90 to 100, showing a case where it's just very obviously strong and very positive. Of note, too, that ER, in this case, I think, part of the thing that we wanted to remind everyone is also just to be aware of where to look when we're doing our staining, because in the liver, as you can see in the image on for the ER, that the hepatocytes also picks up ER staining. So just be careful when you're looking at it, especially on a less obvious type of specimen where it's very small, that you want to be just aware of what else is staining, so you're interpreting the percentage for ER appropriately. So that is our case one. So let's move on to some cyto. In case two, we have a pleural fluid, and thinking about pleural fluid, if you haven't seen a cytology specimen for a while, we think about mesos, we think about histiocytes, but a lot of them are in single cells, where we're not thinking about seeing cohesive clusters. And in the top left image there, certainly we have these very large cohesive clusters of cells that it doesn't belong. It doesn't seem like it's what we would expect in a benign, normal pleural fluid. And so, of course, this could be mesothelioma, but it could also be carcinoma. And with the appropriate workup, with clinical history and appropriate staining, we can certainly work this up and confirm that this is metastatic breast cancer. And we have a beautiful cell block of tons of material. So even with this image, we would say, again, with the guidelines of trying to have about at least that 100 cells to work with, we try to apply that for ERP or HER2 also, just to make sure that we're really giving as accurate of a percentage and interpretation for these biomarkers. So even in that view, we do have a ton of tumor cells to work with. And so we can see that some of the tumor cells, now that we're cutting it into dimension that is forming glands, again, appropriate workup to just confirm that those are indeed metastatic breast cancer, and then you move on to our ERP or HER2 markers. And in this case, I'm showing the complete extreme opposite of what we just saw with the liver metastasis, is that ERPR is just completely negative in this case. So then we have our third case. This is in a lymph node, metastatic breast cancer infiltrating a lymph node. We can barely see in this view of this core biopsy that there is any kind of lymphoid tissue kind of remaining in this view. And so what we're trying to demonstrate in this part, after confirming again that this is metastatic breast cancer, ER and PR are very faint, at least. Let's tackle PR first. We can, I think, pretty sure that this is less than 1%. There is no staining, so PR negative. But ER, if we squint a little bit, depending on how far you are from the screen, there is just that little bit of weak staining. One would argue that is within that range of 1 to 5%. So in this case, the ER was a low positive. So these are kind of 3 cases demonstrating the range of staining within metastatic breast cancer specimens. Any questions before we move on to our next section? All right. Cool. I'm loving all the discussion during our cases so far. Let's see. There we go. Now I get to move on to the next slide. We are going to talk about HER2 immunohistochemistry and FISH. Natural progression from talking about ER and PR. So just a little reminder about HER2 new. What does it do anyway? I feel like we often, do our stains, do our interpretation, and be like, what does it actually do again? And so the HER2 new gene encodes a transmembrane growth factor receptors. And when our HER2 is overexpressed, that influences the cytoplasmic tyrosine kinase and being active. That turns into, growth, proliferation, etc. And of note, HER2 gene is located in the long arm of chromosome 17. I will show this bottom image a lot as we talk about doing especially FISH, and to keep in mind kind of where HER2 is on chromosome 17, and we'll talk a little bit about that later. I'm just kind of curious. I know most of you will probably encounter and interpret HER2 IHC. Does anyone also do FISH also, or do you have another colleague who does HER2 FISH for you? Oh, nice. Seems like maybe you don't have to. So at our institution, our breast pathologists and the cytopathologists do our HER2 FISH interpretation also. So if you find yourself in that shoe when we talk about the ish, we'll talk about some of the nuances of the interpretations. But keep that image in mind. We will pop up again. So HER2 new, is present in about 18 to 25% of breast cancers. It is a prognostic factor in the sense that it's associated with aggressive behavior and outcomes, and is also a predictive factor in predicting the response of the tumor to anti-HER2 therapy. And there's 2 essays. We were just talking about how we're going to talk about the interpretation of IHC, but also in situ hybridization. And a score of 3 plus protein staining is associated with HER2 gene amplification. And we're talking about ASCO CAP guidelines already. For HER2, it's established guidelines back in 2007, and then we had some updates in 2014 and then 2018. And this is based on a formal and comprehensive review of the literature that's been published since 2006. So, all right, without further ado, immunohistochemistry interpretation of HER2. So let's start with score of 0. This should be hopefully somewhat easy. There is no staining or incomplete faint, barely perceptible membrane staining in less than or equal to 10% of the cancer cells. So just no staining. But it gets a little bit more complicated as we go on. With our score 1 in this image, the definition is that there is incomplete, faint, barely perceptible membrane staining in greater than 10% of cancer cells. So the analogy that we kind of want to put into your mind is that, we have a little pencil over there on the right side of things, and if we're talking about membrane staining, the faint, barely perceptible staining you can imagine that the pencil have been drawn around the cell, and if you have that kind of appearance to it, if you're drawing a pencil around the cell, that should be kind of the strength that you're thinking about when you're talking about score 1+. So then what do we think about when we have score 2+? So in this case, true definition would be a weak to moderate complete membrane staining in greater than 10% of the cells. And rather than a pencil, we're thinking about now a pen, like using a pen to draw around the cells. That kind of strength is what you would expect to have when you're thinking about a 2+. And so then how about a 3+ in next, if I can move. There we go. So in 3+, with our definition being circumferential complete intense membrane staining, now we think about like pulling out our Sharpie and really drawing that around our tumor cells. We're really seeing that very clearly. So think about from 1+ being a pencil, 2+ being a pen, and then 3+ you're pulling out a Sharpie for 3+. So in kind of a general overview of the progression of our scoring for HER2 IHC, we have our score of 0 on the top left. We move on to kind of the pencil strength, scoring of 1+ on the top right, score 2+, thinking about a pen, and then a Sharpie for 3+ again. So let's work on some cases. So the case 4 is back to our patient with metastatic cancer to the liver. You can probably recognize the left H&E image that was shown earlier. And now we have our HER2. So also kind of put everything in mind too of, in this case, this was the example of the ER/PR being very strong, almost 100% positive, and now our HER2 in this case is a good example of HER2 being negative, score of 0. And in this next case, we have another patient with metastatic disease. This one is in a lymph node, and on the left you can see very clearly the tumor cells kind of infiltrating the lymph node, and we have a beautiful amount of tissue to work with. For this, the HER2, you will I would say, is it at least a pen that you're drawing around? At least, right? Okay, okay. So definitely, are we pulling out the Sharpie? We're pulling out the Sharpie, and this is a example of a free plus HER2 staining. So, no polling, but for this tumor, what is the interpretation of the HER2 staining strength? We have our H&E on the left, we have our HER2 staining on the right. Not negative. There is some staining. Pencil? Maybe? Not a Sharpie, so not 0 or not 3+. We're kind of in this 1+, is it a pencil, or a 2+, is it a pen kind of area, huh? Dr. Blanco, what do you think?
Definitely chose this case because it is kind of an in-between, a 1 and a 2. Now, generally, my approach in these cases is I would actually call this a 2 because I have a test that I can reflex to give that patient a chance to be treated with anti-HER2. So I would call this a 2, even though I agree it's kind of like a 1.5.
Phone a friend. And then on the, when in doubt, yes, we do try to put it as a 2 and then kind of do our next steps. So speaking of, let's say if this is, we call this a 2+ and it is equivocal on IHC, then what is your next step? What would you do? I think we all know that we were talking about IHC, so the next step would be ISH. And based on this guideline, so sorry that the text is just so small. But we will focus on that golden box there, where if to the left of the box we have, HER2 IHC being 3+, strongly positive, we're done. On the right side of the golden box, we have IHC 1+ or 0 for HER2, and those 2 will still be counted as negative. And then we have our equivocal 2+, where we're going to do more testing, right? Certainly, the other option is, other than reflex testing, would be order a new test, new specimen if available using IHC or ISH, but most of us will probably just go ahead and do the next step, which will be ISH. So now, for those of us fortunate enough to be interpreting ISH on our specimen and don't get to just ask our colleagues to do it, this part is for you. So in situ hybridization, so ISH for our HER2 gene amplification, it could be a single probe HER2 alone or a dual probe, which I think a lot of us do now, certainly with HER2 and then chromosome 17 centromere, so CEP17. And the dual probe for FISH has been basically the standard method for HER2 gene amplification testing since the 90s. And the criteria, amplification status, based on counting at least 20 cells. So, we were just talking about, since we look at this in our own institution, every lab is a little different. So, if you're curious and you don't do this yourself, certainly ask your cytogenetics lab about how many cells do they use. For us, we use 60 instead of actually at least the minimal of 20 cells. And as a cytopathologist, once again, having to interpret the HER2 FISH on metastatic cases where if it's a core biopsy, that's easy enough if you have enough cells. We also, for all these testings, once again, if it's too few cells, we don't do it. But let's say if it's on a fluid, once again, it could be a fluid like our pleural fluid earlier, where you can really obviously see the tumor cells on the cell block. No problem at all. So there's tons of tissue to work with. I feel confident enough to interpret those cells and identify those cells on ISH. But let's say if it's single cells, you can barely tell what's going on. There's a lot of judgment and that lies within how you're going to interpret this. So in those cases, I really do make sure that I have an H&E, first of all, of the cell block, even if it's not my own case. Look at it. Ideally, I will also have a GATA-free, let's say, to highlight the tumor cells that is within that cell block and see how many cells are actually lighting up rather than it's just background mesothelial cells or histiocytes. And if there is certainly enough and I feel confident about it, then I go and look at the fish slide and make sure that I feel comfortable in identifying the actual tumor cells, because once you're in 100x trying to look at a cell block and they're single cells and it's just blue with green and red dots, it could be there could be a lot of room for error. So really make sure that you are building yourself up to the right steps on knowing where you feel comfortable and where you don't feel that it's a specimen that you should really be interpreting the HER2 fish on. So with that said, we have a beautiful image of our chromosome down on the bottom. So HER2 we already know is on the long arm and it's red, highlighted in red. So on the fish we'll interpret those red signals as HER2, and then Sep17, which is at the centromere, that is in green. So now we're talking about interpreting our cells in red and green ratios. So here is an image of the fish in cytohybridization. On the left, we see 2 signals in red, we see 2 signals in green. That is what we would expect as normal. And then on the right, lots and lots of red dots within each of our cells. Certainly think about the way that our slides are also made to where it's very two-dimensional. Sometimes you have to make sure you count enough cells so you see the appropriate kind of number of signals that is present on each cell. But in this case, it's very obvious that there is a lot of red. Red means HER2, so there is HER2 amplification in that sample on the right. So there is another algorithm to think about when we're doing in situ hybridization. If we go to the left, we have reach the point of whether to go to the left or to the right, and that is based on our HER2 Sep17 ratio. And the magic number is 2. So if it's greater or equal to 2, you go to the left side. If it's less than 2, you go to the right side, to the red. And the next row, you'll find that we have 5 options. We have group 1 to 5. Easy enough if we focus on the extremes. So group 1, if we go to the HER2 Sep17 ratio that is greater or equal to 2, we go down to group 1 when the next step would be the average HER2 copy number, being the magic number here is 4, so equal or greater than 4 signals per cell, and that is positive and you're done. You're in group 1. If we go to the very opposite end of things, we have group 5, where we start off with HER2 Sep17 ratio less than 2, and in that case, we fall into group 5, where we'd have the average HER2 copy number less than 4 signals per cell. And then if you have meet those criteria, you're done, you're in group 5, HER2 is negative. Gets a little complicated when we talk about the group 2, 3, 4, because those will be based on, of course, first the HER2 Sep17 ratio, but then you can fall into those groups if the average HER2 copy number is not what you expect in group 1 and group 5. So there's a lot of numbers here. So in these cases, we're kind of talking about the range of like 4 signals per cell, 6 signals per cell. And all of these will require additional workup. So let's kind of move on to the next part of this discussion. So question 3, this one is a polling. Reflects fish study in a case with equivocal IHC, how would you report the HER2 on this case if the HER2 sub-17 ratio is 1.4, and then the average HER2 signals per nucleus is 4.53? Let's see if I can. So ratio 1.4. Our cutoff was a 2, right? And then signals for per cell 4.53. Let me start the polling. Oh, we have our. Uh-oh. Oh, okay. Looks like it's working. So how would you report this? So group 1, 2, 3, 4, or 5. All right, we have 2 people voting for group 3. One for group 4. I'll give everyone a little bit more time. All right, seems like we're skewing group 3, 4. We're definitely finding ourselves in that dilemma. We certainly are not in group 1 of 5, not group 2 based on the ratio. So yes, then let's think about where we are landing in groups 3 and 4. So let me just move back towards this image. So group 3, the criteria is that HER2 copy number is greater than or equal to 6 signal per cell, and group 4 is HER2 copy number in between basically 4 and 6 signals per cell. So the answer would be actually group 4 in this case. But we are basically kind of going into that category. So perfect. So just a little bit of details. When we're finding ourselves into group 2, 3, 4, we basically have to do a little bit more workup, have another person counting more cells, trying to find and confirm whether or not we're going to see the same results in the ISH. And depending on what the results are, then you can, if it's confirmed, let's say in group 2, HER2 is considered negative, and you put this long comment in your report. In group 3, again, depending on what you confirm, you will go down the algorithm for what to report. And then group 4, again, depending on what the results are, and if you confirm the same results still, then you also put in a comment with your report when you're reporting out as group 4. So overall, just kind of a overall summary of things. Easy when you're in group 5 or group 1, we have either just negative or positive, but then based on the other groups, if you find yourselves in 2, 3, and 4, it also comes into play of the IHC interpretation too, and whether or not that HER2 will be interpreted as positive or negative. So I'm going to move on to the discussion of HER2 low with Dr. Blanco.
All right. I'm sure you've all heard about HER2 low at this point. I see some fun faces here in the front. All right, so HER2 low, what is this? So the Destiny Breast 04 clinical trial found that patients with low HER2 expressing metastatic breast cancer benefited from targeted antibody drug conjugate therapy, specifically trastuzumab deruxtecan or TDXD. And they found that 55% of breast cancers actually fall into this HER2 low group. They had 494 participants, and they had one group treated with the TDXD and the other group with chemotherapy, which, as you can see in this chart, was physician's choice. And what they found was, on the chart up here, which represents progression-free survival, and the chart down here, overall survival, what they found was that there was 50% lower risk of disease progression and 36% lower risk of death in the HER2 low group that was treated with TDXD. So they concluded that TDXD significantly prolonged progression-free and overall survival among previously treated patients with HER2 low metastatic breast cancer, regardless of hormone receptor status. So we have another Mentimeter here. What is the actual criterion or criteria for classifying a breast carcinoma as HER2 low? Is it score 0 on IHC, score 1+ on IHC, score 2+ on IHC with a concurrent non-amplified FISH, or with a concurrent amplified FISH? And maybe it's more than one. All right. I have 57% saying 1+ on IHC and about 43% saying 2+ on IHC with a non-amplified FISH. And those are the exact definitions that Destiny Breast 04 clinical trial used to classify patients as HER2 low. So HER2 IHC score 1+ or score 2+ with a non-amplified FISH. So what is this trastuzumab deruxtecan or TDXD? So again, this is an antibody drug conjugate. So the antibody will find the HER2 and it is bound to the DXD component, which actually will lead to DNA damage and apoptotic cell death. So there's a cleavable linker with the antibody and the drug that frees the cytotoxic payload from the antibody and allows it to kill the tumor cells. And what's interesting about this drug is it actually has anti-tumor effects on the neighboring cancer cells as well. So there's a bystander effect. So it doesn't just kill the tumor cells that the antibody attaches to, but even the neighbors. So given this, there was actually an update to the HER2 testing guideline in 2023 from ASCO and CAP. So the US FDA expanded approval of the HER2 antibody drug conjugate, TDXD, for metastatic breast cancer patients, including those with HER2 low tumors. However, the guidelines do point out that this does not support the use of a HER2 low interpretive category. So it's okay. We're okay. Just the complicated guidelines that Dr. Choi went through. So the reasoning for this is the Destiny Breast 04 trial actually did not look at or include IHC 0. So we don't really know. We don't have evidence to support whether a 1+ or a 2+ FISH negative case is more predictive of response to TDXD compared to a patient who is IHC 0. And the FDA expansion was only based on clinical trial eligibility criteria rather than a true predictive indication for HER2 testing. So what are we supposed to do? So again, there's no changes to the prior recommendation with regards to testing. And with regards to reporting, the new guidelines do suggest adding a new note specifically indicating that HER2 IHC 1+ or IHC 2+ with a non-amplified FISH may be eligible for treatment that targets non-amplified, non-overexpressed levels of HER2 expression for cytotoxic drug delivery. And at this point, IHC 0 results do not result in eligibility criteria. So we add this note in order to allow our patients to be enrolled in these clinical trials. So some things to keep in mind, since we now have to distinguish between 0 and 1+, is examine the IHC slides using the standardized ASCO CAP guidelines that Dr. Choi went through. Examine the HER2 IHC at a higher power, 40x. And then if it's kind of a tricky case, you're in between a 0 or a 1+, show it to a friend, which is one of my favorite things to do. And then they also suggest using controls with a range. So you have punches on top of your slides with 0, 1 plus, 2 plus, and 3 plus. And also, as we talked about earlier for the hormone receptors, really pay careful attention to the pre-analytic conditions for both primary and metastatic sites. Now, this has been a hot topic for a couple years. There was a companion meeting at USCAP a few years ago, led by some of the experts in the field, including Dr. Schnitt, and they did point out there are a couple problems with diagnosing HER2-low breast cancer. One of which is the fact that the HER2 IHC assays were developed to detect HER2-positive breast cancers, so the HER2 3 pluses. And given this, there's really insufficient dynamic range to be able to reliably distinguish between a HER2 0 and a 1 plus case, because that wasn't what they were meant for. That's not why these tests were developed. And in addition, there's very poor inter-observer reproducibility in distinguish a HER2 0 from a 1 plus. So right now, it's very exciting that we have something new to treat our patients that are HER2 low, but we need to look at another way of really distinguishing between a 0 and a 1 plus. And some of the things that are being looked at currently include quantitative protein assays, maybe help from AI, and transcriptomic methods. And I'm not going to go through it in detail, but I don't know if you guys have heard, but there's a new group as well called the HER2 ultra low. So we'll see. We'll see what happens. All right. So we're going to go on to our last topic, just talk about some of the more contemporary markers that we use to determine breast origin.
All right. Just a brief kind of review and a little bit more detail on what is kind of new in this area. We, of course, have already mentioned GATA, but we're going to talk a little bit about SOX10 and TRPS1. This is certainly a wheelhouse of, like, if you're in the cyto world, I think a lot of our trainees and even ourselves, where we really learn how to use our immunomarkers to work out metastatic diseases, especially when it's unknown of site of origin. So we have a lot of options to work with, but I think we want to start with, if we're going to say, hey, the patient is coming with metastatic disease, we have no idea where it's coming from, really starting with like CK7 and CK20 is great. Most of us will recognize this image in the Handbook of Surgical Pathologists, quick reference, and breast cancer kind of lives in that top left box of being CK7 positive and CK20 negative. And from that point on, you can kind of guide yourself in what else you want to roll out. So let's say if you're in a pleural fluid, of course, lung cancer is probably more common, but breast goes there too. So then you, with both of those categories, let's say going into CK7 positive, CK20 negative category, then we use some more specific markers for breast origin, and the traditional ones, we have GCDF-P15 and mammoglobin. They work well for tumors that are well differentiated, but they tend to get lost in poorly differentiated ones. And now, of course, a lot of us use GATA-free, but as someone who also does GU, certainly GATA-free is something I use for urothelial, and we know that there's papers out there that GATA-free stings for a lot of things, so it's not perfect, but the sensitivity is 15 to 60%. But in a company with other things, in addition to clinical history, we can certainly be able to use this to kind of confirm our breast origin. And so let's talk about some newer-ish markers that we were using in this kind of setting. So we know about SOX10, that's for diagnosing neuroectodermal tumors. We use that for melanoma, it works great. But it's also been shown to express in benign breast tissue and in some breast cancer. And recently, it's been recognized as a useful marker for triple-negative breast cancer. So when, let's say, all of our other traditional markers, even GATA-free, might fail us and it's not staining in those cancers, SOX10 might come into being very handy in that case. So we have a patient, a young patient, unfortunately, she presented with a mass in the occipital condyle, so it kind of in the base of her head, and nothing else. She was pregnant, 30-some-year-old, and this is what it looks like. So a lot of workup needs to be done. Where is this tumor coming from? Some even think that it's not carcinoma based on the location, but this tumor ended up being a metastatic breast cancer, and that was how she presented. So mammoglobin was staining beautifully, GCDFP15 also, you can see some staining, GATA3 is beautiful. You don't need to go into like using SOX10 at this point. She's going to then do the get biomarkers for ERP or HER2 testing. So again, as a cytopathologist, we are encountering breast cancer everywhere. This is in the CSF. Oftentimes, we get maybe at most 2-3 cells to work with, but what the tricks would be, there's always a little bit of red blood cells in the background or lymphocytes. Compare the size of that to the cells that you are suspicious of. A lot of carcinoma, when it's in the CSF, really have these kind of like funny looking cytoplasmic rim to it. That's another way of thinking about it. And then of course, if you really want to, what we like in our lab is you can certainly use immunocytochemistry, and in this case we can reset a slide, stain it with a stain. You can use any stain, to be fair, as long as you validate it. However, we prefer validating stains that have nuclear staining because it's just easier to look at in those specimens. We, every now and then, I don't know if anyone else encountered, we have a clinical team and be like, can we do molecular on the CSF? And we're like, unfortunately, no. But at least we can confirm that this is metastatic breast cancer if we need to on stains. And our last case is another patient with metastatic disease going into the bone. In this case, GATA3 was basically negative. We know in her history that she has triple negative breast cancer, and the SOX10 on the bottom right is beautifully staining. So more interesting and exciting part to wrap up our talk would be TRIPS1.
All right. How many of you have heard of TRIPS1 or used TRIPS1? Awesome. So here's an H&E case of an invasive ductal carcinoma. Here on the right, you can see nice nuclear positivity with GATA3, and in the middle, also nice nuclear positivity with TRIPS1. So TRIPS1 is trichorhinopharyngeal syndrome type 1. This is a specific gene for breast carcinoma that was found more recently in an analysis of the Cancer Genome Atlas database. And here is another case that you can see is nice and strongly positive for TRIPS1, but GATA3 maybe some rare, very weak positive cells, but overall it looks pretty negative. So we actually took a look at this at Northwestern, and we looked at some TMAs of triple negative breast cancers, and here is an example of a TRIPS1 positive SOX10 negative case. And we also use whole slides, and here's an example of a case that is TRIPS1 positive, but SOX10 negative. And then here's another one that's the opposite, which was TRIPS1 negative, but SOX10 positive. Overall, when we were looking at this, we found that TRIPS1 had a better sensitivity, 92% compared to 64%. Compared to SOX10 in our triple negative breast cancers. However, there was a little bit of a lower specificity, which you can expect with higher sensitivity, but it's still pretty good at about 96% compared to 98% for SOX10. One thing to note is that TRIPS1 was also positive in 2 of 3 primary chondrosarcoma cases and 1 of 3 primary osteosarcoma cases. Now, this is likely related to the fact that TRIPS1 actually also plays a role in the mesenchymal to epithelial transition during development of several tissue types, including cartilage and bone. The good thing is, usually cartilage and bone tumors won't be in our differential. So here's just showing you a chondrosarcoma and an osteosarcoma that's positive for TRIPS1. So again, overall, we found that TRIPS1 was more sensitive and has really good specificity, about 96%, and therefore can be very useful, especially when you're dealing with a triple negative breast cancer. So just a quick summary. PDL1, so Pembro is FDA approved in patients with PDL1 positive, locally recurrent, unresectable, or metastatic triple negative breast cancers, specifically with the use of DACO-22C3 and a CPS score of more than or equal to 10. And again, as Dr. Choice pointed out, should have a minimum of 100 viable tumor cells in order to interpret the immunostain. Pembro is also FDA approved as neoadjuvant and adjuvant therapy for high-risk early-stage triple-negative breast cancers. And this one is approved for the overall population without a need for a companion immunostain diagnostic test. And then 4-year biomarker testing, which is really important to help guide our clinical colleagues with regards to hormone or anti-HER2 therapy. Please pay special attention, including to your pre-analytical conditions, both for your primary cases as well as for your metastatic cases. And for ER and PR, anything more than 10% for ER is positive. Between 1 to 10, we call low positive now, and then less than 1% would be negative. And then for HER2, we went through the various guidelines for IHC interpretation, which is similar to the prior guidelines. There are updated guidelines for FISH interpretation. There's now the groups 1, 2, 3, 4, and 5. And we look at both the HER2 sub-17 ratio as well as the average HER2 signals per nucleus, with a need for additional workup when you're in that middle group of 2, 3, and 4. And for patients with metastatic tumors, those with HER2 low, which are IHC 1 plus or IHC 2 plus with a non-amplified FISH, may be eligible for TDXD treatment. So it's important to add that note in your report. And then for markers of breast origin, we have the classic markers, CK7, GCDF, P15, and mammoglobin, and then more contemporary markers, GETA3, and SOX10 and TRIPS1, which are particularly useful in triple-negative breast cancers and in very limited scant cytologic specimens because they are all nuclear. And with that, we thank you for your attention.